Sorry, Mr. Chairman, I didn't hear you. Thank you for your testimony. I'm going to take the opportunity here while you're here because of your expertise to ask a question that interests me, and it is related to the opiate crisis, and that is any research that's being done in the field of analgesics that are not related to pain, pleasure. Is there anything being done to develop anything like that so people who do indeed have serious pain are able to get treatment?
Absolutely. So the reality is that opioids are not necessarily the best option to treat chronic pain. In fact, there is something called opioid-induced hyperalgesia, and what that means is an increased pain due to the opioids. In addition, they cause hypogonadism and other sorts of long-term problems, bone demineralization problems. So being on opioids long-term, even as prescribed, is not very good for your body. And so it's not necessarily a good health approach. Now, for acute pain, they do work pretty well. But the quandary is, what do we do about the chronic pain? So when acute pain becomes chronic pain, what do we do about it? So you can't necessarily give somebody a nerve block. And by the way, for acute pain, if you're in a hospital setting, or if you're, theoretically any physician could do a nerve block for most areas of so regional anesthesia, that's called. So there's nothing addicting about that. You give an injection at the point on your body where the pain is, it blocks those nerves. The problem is it only lasts for a few hours. But for, a brick that landed on your toe and you're in the emergency room and you need to get the fracture set, regional anesthesia is fantastic. And by the time when the fracture is set correctly, the pain should resolve. So in that setting, you don't even need to be exposed to opioids. So there are a lot of reasons why you don't need to be exposed to opioids in the first place. Furthermore, non-steroidal anti-inflammatories, which are over-the-counter, such as Advil and Tylenol, although that's not an NSAID, but they are phenomenal analgesics. So there are a lot of reasons why you can avoid, and that statistic that the judge mentioned earlier, I think it's over 80% of the world's opioids are consumed by this country. Why is that? Why do we feel the need to treat do we just have more pain in this country, or do we feel like the rest of the world, where they don't even necessarily have the same safety requirements for things, they must have more injuries, and there's certainly larger populations, and yet they're not consuming opioids? How are they surviving with that pain by comparison? So there's certainly a perspective on pain in this country, perhaps, that it needs to be zeroed out. And the reality is, from the pain management side, that's not a reasonable goal. It's not I shouldn't say reasonable, it's not a goal that you should look for as a metric of success. You should look at functionality. So the patients that I was treating, and I still do have some chronic pain patients who are thankfully off opioids, they look at, what can I do today? Can I work today? How do I get there? And so perhaps one patient coming to mind that has to travel to New York. So for her, getting to New York on public transportation is very painful for her. So can we make an accommodation for her so that she doesn't necessarily have to go to New York as frequently, or when she goes there, she can have a better place to sleep overnight so that she doesn't wake up with back pain the next day that's worse from what it was before? So there are a lot of, I think Dawkins said, common sense things that we can use to try and mitigate the pain without using opioids. And then to answer your question, there are absolutely research. There are some interesting things happening. There's a particular sea creature that has some sort of stinging ability that numbs its prey. They're looking at that and seeing if they can, then it's in more advanced stages of testing. It's not an opioid, it's not addicting in any way, and it seems to have some very good analgesic properties. So in addition to the numerous things that already exist, there are some things in the pipeline as well.
Could I ask a follow-up to that as well?
Go ahead.
You talked about naltrexone. What about Suboxone, and what are the differences in the two and the pros and cons of each? Because we hear an awful lot of the negatives about Suboxone, at least I do in my area.
Absolutely. I'm glad you brought it up. So in my practice, 95% of my patients, I would say, are the buprenorphine route, the Vivitrol or naltrexone route, and maybe 5% are the buprenorphine Suboxone route. And why is that? Because you can use buprenorphine as part of a detox. That's a totally different thing. But what you're asking about really is maintenance treatment, so ongoing. So one of the initial challenges is, for about a week to 10 days from your last use of opioids, you need to be detoxed in order to get onto naltrexone, whereas you can start the Suboxone sooner. The reason being both can precipitate opioid withdrawal if given too soon. But you can get started sooner. So that initial period is really the key difference, but there are a lot of ways around that. And as I said, I do this in an outpatient practice where people are in the real world, in the lion's den, where they might even be living with somebody who's actively using, and I'm trying to detox them. That's a lot more challenging than going to a country club where you're getting massages every day and detoxing at the same time. So it is possible to do it, is my point. And nonetheless, they just recently published in The Lancet, which is a very good peer-reviewed journal, that once you get past that detox period, the success rates are very similar, and I would actually argue better with naltrexone, because at the end of the treatment period, if you're on naltrexone and you decide to stop, remember, it's not an opiate. You don't become dependent on it. The day you stop is the day you stop. You don't have any withdrawal from it. It's easy to stop and get off of it. So if you're I don't want to say cured, but if you're at a point of stability where you may no longer need it, you just get off of it. If you're on Suboxone for a year, now you have a real bear to get off of that Suboxone. That might take you another 6 months to do it with the least amount of risk possible. Sure, you could get off of it in 4 to 6 days, but you're probably then going to relapse, which is that's clearly not the outcome we're looking for. So that's sort of the biggest difference. Then there's a legal component of it. There's no street value to naltrexone per se. I would love it if the world of drug addicted people abused naltrexone. That would be the greatest thing in the world. It's not going to happen, but they will abuse Suboxone, and it has a street value of roughly $8 per strip. So which is how it's usually taken under the tongue, or the tablet form under the tongue. Either way. So what happens is somebody goes to their doctor. Well, let's start with the better analogy, or the proper analogy, which is somebody goes to their doctor, they're addicted to opioids, they get on Suboxone and they take it every day as prescribed and they do great. If that were the majority of cases, I wouldn't argue against it, but that's the minority. Unfortunately, the majority is there's an interval period where the doctor sees them more regularly, and then once they've demonstrated, usually through urine drug screens, that there are no other substances on board, they spread those appointments out to every month or every couple months, and what happens is, unfortunately, many of those patients will get that prescription, which now has a street value. Let's say they have 30 days times $8. So now if they sell those on the street, they might keep 5 or 6 of them for themselves. They can sell that, use that money to buy illegal drugs, such as heroin, and then right before their doctor's appointment, they can take those last 5 that they reserved, detox themselves from the heroin, and get back on to the Suboxone, so that when they see their doctor, the urine drug screen shows just Suboxone and no heroin, and it looks like treatment success, but in reality it's drug dealing.